about making the case for prevention. We hear from folks all the time that whether it's talking at a local level to a local community leader, a funder, a principal, a health department commissioner, or up at the state level to legislators, and beyond that nationally, that there seems to be a need for more information about how do we help other people understand the importance of prevention, the value of prevention, as well as what prevention involves. That it's not, oh, you know, don't do drugs, drugs are bad, silver bullet, simple something. But it's more complex than everyone would really like it to be. So we wanted to focus on that today. And before we get started with some key themes that we're going to organize this around, I think it's important to just acknowledge there are some barriers that all of us will address if we are to successfully advocate for prevention, whether at the local, state, or national level. And one thing we as preventionists don't focus on very often or don't talk about, we hear about it more from our treatment brothers and sisters, and that is the stigma of substance abuse. But that is a huge piece of this puzzle as to why substance abuse prevention is not more supported, because there's kind of this belief that people do it to themselves, and there's not a public health and we're only blaming the person with the problem. So we do need to address the stigma of substance abuse as we look at advocating for prevention. We also know that the public has a really big misunderstanding and very much an oversimplification of this problem. And we often hear things like, you know, if people just knew how bad drugs were, then they'd never do them. So if we can just scare them and scare them some more and tell them all the worst things that could ever happen, then they'd never do it, right? If that prevention's just for kids. There seems to be a real misperception that that's the only target for prevention strategies and services, which is definitely a myth and a misperception, as is that prevention is prohibition. When it comes to the legal drug of alcohol, hopefully you all know and are familiar with the research that shows that adults can consume alcohol, not all adults, but many adults can consume alcohol in low-risk quantities and frequencies. And some of this, I think, comes from the previous balloon. You know, that we talk about abstinence for kids because of their social, biological, and psychological development, and particularly their brain development. And so folks hear prevention and they assume it's prohibition across the board, across all ages. So we need to look at prevention across the lifetime and help people understand prevention doesn't mean prohibition, right? And that prevention is simply not doing something. That if we just focused on what people shouldn't be doing, right? That's what prevention is. And again, prevention is more complex than everyone might like it to be. A few other barriers that I know that we would be running into that we'll talk about today, that is our remediation-based culture. That this isn't just a problem with substance abuse. It's a problem with many social and biological and health ills that our communities face, that we seem as a culture in America to be much more focused on treating or throwing money at a problem once it's already in place and occurring. We wait for the crisis. And so we need to definitely try to change that philosophical stance of the culture. So we're up against a lot there. We also know when it comes to prevention, the benefits of the work we do are future-based and are therefore hard to quantify and hard to measure and are not something that we always see an immediate change from. And that's certainly something that's hard, particularly for politicians, to wait around and buy into, right? Because they're looking for something they can stump on right now. And then, of course, prevention, part of that is that prevention is tough to quantify and therefore tough to justify for folks who don't understand it. And we need to get them to buy in more into prevention. So our own local data is going to be a big piece of that puzzle as well. So to organize this hour and look at some ways that we can address these barriers, here are some things that we think are some key advocacy themes. So I've organized the presentation according to these themes. We're going to first look at the economics of this and how we make the case that prevention is cost-effective and kind of challenge that remediation-based culture headset, which is a much more expensive way to go, right? We also need to frame substance abuse as a public health issue that requires a public health response, and that the scope of that response certainly includes preventative measures, as it would with any other public health response. and that will help deal with some of the stigma piece if we can frame that way and be more successful at framing that. We also need to really help people understand that prevention is a science. It's a discipline and a science. We have many years of research, and why would we spin our wheels doing things that have already been proven not to work when we need to just access the research that already exists? And that in doing that, our prevention efforts need to be part of a planned approach. We can't be scattershot in what we're doing. Communities need to be more collaborative, have a larger vision and a strategic plan of everyone knows their role and their part across sectors. So being part of a community-wide planned approach. And part of that is helping people widen their lens, that prevention is more than just education, and that in fact what we need to do is invest in comprehensive evidence-based prevention across the lifespan, across sectors in the community, and across strategies, more than just education. So those are the themes that we're going to work from today. So let's start with that first one. Excuse me, that prevention is cost-effective. So I'm not going to spend a ton of time on all the costs, and I do have a few statistics around some of these, but depending on who you're speaking to as you look across all these different bullets, just putting on your to-do sheet, you got to figure out who you're talking to, what's in it for them, what is their focus, and what costs will speak most highly to them. So depending on your target for who you're trying to persuade and advocate with, you may need to go and find some great stats specific to these issues. I'm going to look a little bit more large picture and large scale today at this. So as we're taking a look at the estimated cost to society per year by our three main categories, we know that tobacco costs America as a whole about $289 billion, alcohol $223 billion, illegal drugs $193 billion, putting us over $700 billion. So let's break these down a little bit more and look a little more at tobacco. We know the industry of tobacco is spending billions each year, keeping the money rolling in, and that's a big, particularly on the media message and community norming front, much less the access and availability issues of keeping it easily accessible in communities. We know that money is well spent from their point of view, right? But unfortunately, every bit of money they spend is making more costs. As more people use it, the cost to America, to the United States and the taxpayer is about $289 billion a year, as we said. How does that break down? For direct medical costs, we're seeing about $133 billion. In lost productivity, that's a great angle depending on who you're advocating with. Talk workforce, talk the economy. Jobs are the focus right now, especially with legislators. So we're looking at lost productivity of $156 billion just from tobacco alone. $5.6 billion a year in lost productivity from exposure to secondhand smoke, and that's something that's very unique to tobacco, and something for us to definitely make sure we're emphasizing, especially when we're talking workplace. So as we're looking at this costs and expenditures, I think it's important to note, and I missed putting this in the slide, but remember that the cost overall was $289 billion. That was in previous slides. Everyone talks about, yeah, but it's taxed, and we've got all this money that helps offset that. It doesn't offset it at all. Put $289 billion in costs next to $25.7 billion in income, revenue that states are collecting as a whole from tobacco taxes, and by the way, that's also from legal settlements with the tobacco industry. That's not just the tax revenue. Now, when we're looking at how much of that is even spent on prevention and cessation, okay, versus budget shortfalls and other ways those funds get robbed in our communities and in our states, about 1.9% of that $25.7 billion is being spent on prevention and cessation programs. And this is according to the CDC. There is currently not a single state in America that is funding tobacco control programs at their recommended level, which is still recommending less than 15% of the 25.7, about $3.3 billion. If they would just do that in every state, that would put it at recommended levels. So we're not even asking for 100% of the revenue, right, in order to really get ahead of this and deal with the cost. And a lot of that's about a strong tobacco lobby. So they're making their case and whining and dining. We've got to make the public health case and use dollars and cents to do it. So I'm hoping some of those stats helped you. The CDC does have more information if tobacco is a big focus for you. Taking a look at alcohol, breakdown of that $223 billion per year. In workplace productivity, we see about 72% of those that $223 billion comes from workplace lost productivity. The healthcare costs are about 11% of that figure. The criminal justice and law enforcement costs, shockingly, are lower at 9%, and the motor vehicle crashes are about 6%. So when you look at that $223 billion a year, excessive drinking is costing, if you put that across the population per person, about $746 per person. So that's a real important way to frame this, and not every person drinks, right? We know about 40% of adults in America don't drink at all. And it's our heaviest drinkers that are causing most of these problems, not our low-risk or moderate drinkers. So a very small percent of our population, only about 30% of the people who drink at all, are costing an awful lot of money, per person there across America. As you take a look at the illegal drug costs, we said that was about $193 billion per year. And those economic costs break down into crime and health as well as workplace productivity as well. I'm going to give you some links in the follow-up email to some workplace productivity stats that will definitely get for you. But that economic piece is a real important piece of this puzzle. If you want to compare this with other health problems, which might be a nice advocacy angle, diabetes costs about $174 billion per year. And the economic burden for addiction is twice that of any other disease affecting the brain, including Parkinson's and Alzheimer's. So some great stats out of the National Drug Intelligence Center and Center for Disease Control. Giving you a few more workplace stats, and again, we'll give you a link to a lot of good workplace stats in a follow-up email that just there wasn't room in the presentation for it, but we'll definitely link you to it. We know that I would hope everyone knows, but we need to help lay people understand and decision makers and stakeholders understand that the stereotype of the Skid Row bum unemployed, with the bottle in their hand or in a back alley looking for a fix is a big stereotype. And an awful lot of people with alcohol and drug-related problems, including addiction, are employed and working. About 60% of people with active alcoholism are employed and working, about 74% of heavy drinkers, 66% of drug users employed and working, bringing the effects of this into the workplace with them. And they're causing a great deal of workplace losses. About 30 to 50% lost productivity, missing about 3 weeks more per work per year on average. And if I don't show up to work and the work still needs done, someone else has to step in and do it. So you've got coworkers, picking up the slack or covering my mistakes or doing double duty, and that's just not fair to the folks who showed up. 47% of on-the-job serious injury accidents have alcohol or other drugs involved, and of those on the job that end in a fatality, we're looking at about 40%. So those last two stats, close to half of the on-the-job accidents are alcohol and other drug-related. One study put the cost of each substance abuser, and just to point out, this is without an accident. This is just in things like lost productivity, absenteeism, tardiness. About $7,000 at the low end of the range per year, $25,000 on the high end. Again, that's without an accident even happening, because an accident can take that number way up. So there's some real costs where the bottom line and the profitability of a company is leaking out the door, and the folks that are most affected by that are your small mom and pop companies, which are the backbone of the American economy. So being able to really articulate that is an important piece of this puzzle. Again, we're going to send you some additional links to some great stats to make the economic workplace angle as part of your advocacy. Some other ways to look at this and help people understand, we're always hearing about education and there's not enough money for good education in schools and we can't pay teachers better, et cetera, et cetera, et cetera. Well, the burden on the already strained budgets of schools, SAMHSA is reporting through a study that substance abuse is adding about 10% to the already strained budgets of our schools of just costs that it causes, diverted staff time, right? Having diversion programs available, just dealing with substance abuse as it's coming into the school. That's about $41 billion a year. Now, the next slide is kind of what I call the no-dust slide, but as a general statement that you can make, pardon me. I'm very sorry. As we look at this, as use and abuse of substances goes down, we know, and it's so clear in so many studies, that spending in health care goes down, spending in unemployment costs go down, court, criminal, child welfare costs, all that goes down. So the more we can do to prevent use as well as abuse, the more money is saved, right? So one way that I would really encourage you to look at this, instead of only just focusing on the cost, is to use more positive language and maybe change our frame to this kind of a slide where we're not saying substance abuse cost, 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 cost. We're saying here's your benefits of investing in effective prevention. And even just those words at the top of that slide imply more already because it's saying effective prevention. And then they'll go, well, tell me more about what you mean by effective prevention, right? So you're planting seeds that not all prevention efforts are equal, right? So just in how that's already framed. And then you have all this whole list. And again, some of those may be a stronger highlight depending on who you're speaking to and what's in it for them or for their system or their interests, right? What are they a stakeholder? What do they have a stake in? So encourage you to paint it in the positive, all right? And then that gives you a way to go, well, let's articulate what is the return on investment. The benefits of the benefits of investing in effective prevention have a return on investment. And some of you may be familiar with a study that found that we save about $10 for every dollar spent on prevention. And that was out of the Washington State Institute for Public Policy. So that's an excellent articulation. For every dollar spent in prevention, we're saving $10 in shoveling up the mess that substance abuse causes, right? So it's a worthwhile investment. That's an incredible return on investment. If you're advocating more around school-based drug prevention, some of you may have seen some other studies that were out there. Another way to look at the return on investment from school-based came from this study that was reported in Drug and Alcohol in 2004. What we can and cannot expect from school-based drug prevention. They're seeing a social benefit of reduced substance abuse at about $804 per participant that received the program. And they had specific programs that they were finding this connection with. And then the program cost per participant was only $150. So that's a great return on investment. You know, for $150 spent, you're saving $804 from reduced substance abuse as a result. Excuse me. All right, we've had some water. Maybe things will get better here. My throat was fine until I put a microphone in front of my mouth. All right, so I apologize for that. All right, it's that time of year, right? We're all dying here with the cold. So unless you're lucky enough to be calling in from Hawaii, and then I don't want to hear from you. All right, so as we're taking a look at this, there's so much solid information, and there's so much more in that report, by the way, that you're seeing quoted on your slide from Drug and Alcohol of 2004. Really encourage you to seek out that article if you're really focused on school-based prevention and making a case for it particularly. So we've been able to articulate over time with more economic kind of studies that are out there, and there are others, that prevention is cost-effective. And yet our culture does not invest in it. The case has been made again and again and again, but we still don't get there. And some of that is because we are up against a remediation-based culture. We'd rather throw money at the problem instead of the prevention of that problem. So instead of money that could be spent on things like education, healthcare, quality of life programs, substance abuse is costing so much that instead that money that's in our public budgets is being thrown at cleaning up the problem. All right, and we're losing out on things that make us more competitive as a society, healthier as a society, certainly much more progressive and more technological development, and puts us ahead of the curve. Education, healthcare, quality of life, that's the quality of a society. And that money's being robbed by cleaning up the problem. So if we could get that return of investment for a much smaller amount of money, you know, for every one of those $10 flying down there to the problem, we set aside $1 for prevention, that's more money. Those $10 come back out of the problem and go back in the bucket for important things that a good society values, right? And some of that, again, of why we're so remediation-based is, again, that prevention's benefits are recouped in the future. And particularly since the crash of '08, when budgets got even tighter than they already were, our priorities shift again and again to the now. And while the economy's coming back and there's more money coming back into social services, so much of that is still going to cure or cleaning up the mess, right? And that we're not getting the money back into prevention again because now we're in a habit, you know, that we spend it on the problem. So we're putting out fires all the time. And, again, we've got to acknowledge that politicians favor quick results so that they have something to stump on, and prevention's results are not quick. It doesn't work that way. So what ends up happening is this cycle that you need to help these stakeholders understand that the problems persist and they even progress as we are in this vicious cycle of always putting more of our investment into cleaning up the mess than preventing the problem. And as the society ills worsens, the cost goes up. And as the problem worsens, right, and the costs go up, and again and again and again. So we need to help them see the value in breaking that cycle and investing dollars in prevention. It's not just that it's good public health practice. We need to focus on this is good economics. This is a good economic practice. Otherwise, we're throwing good money after bad, right? So now we've made that economic case. Let's hit our second theme that we talked about and bring in this public health issue and helping them understand and see substance abuse as a public health issue that requires a public health response. And I thought maybe an analogy would be helpful, and this is the one I happened to pick for a big public health issue. If anyone's bothered by insects, I apologize for what is on your screen. I'd like to just ask people to imagine, what if we only treated the active cases of West Nile virus and malaria? And that's all we were doing. That was it, waiting for people to get sick and just simply treating any active cases of insect-borne diseases, okay? Or if we had simply said as our only prevention, hey, don't be around mosquitoes. Mosquitoes are bad. And we didn't do a true public health response across the spectrum of prevention, intervention, treatment, and environmental and individual approaches. So when it comes to mosquitoes, the public health approach has been used, and you can help even someone who's not real tied into public health understand this. You don't have to use the language that you may or may not know. Some of you may know that the mosquitoes representing what they call the agent, and that little figure of a person is representing the individual, and then we've got the environment. And how do these all interact? You can just do the analogy. Okay, so up here we've got the mosquito. We know that's where the diseases are being carried, insect-borne illnesses. We know that they can infect people, and we know the environment plays a role. And look how comprehensive we've been in our prevention. And you don't have to do it all, but give a couple examples. So, that relationship between the individual and the insect is, wearing long sleeves and wearing pants and having your repellent out, and the relationship between the individual and the environment is being clear about when are insects out more, and not being out at dusk and dawn and overnight, and, better to be outside during certain hours. And even that connection back to what we do between the environment and the mosquitoes themselves, keeping the tall grass mowed down and not having, tires with standing water, and what do we do with our pools, and are they treated appropriately? After Katrina, it was a big issue after Hurricane Katrina that we had all these standing pools and all these empty houses and all this rainwater and sludge water in these pools that were just breeding and breeding mosquitoes. It was a huge investment to get out there and treat that, much less the environmental pieces, around spraying and keeping the population down. And the analogy for that to alcohol and other drugs, in a sense, is the access and availability argument. If mosquitoes are proliferating in our community, there's going to be more disease. If there's a proliferation of access to alcohol or some other drug, there's going to be more problems with that alcohol or with that specific drug. So let's make that connection. So we've shifted our picture, and all we changed up here was what the agent is. And now we're talking about alcohol, tobacco, some other drug. And, we know that within the individual, there's attitudes, beliefs, individual risk and protective factors that need to be addressed. And in that relationship between the person and the substances, we have their own experience. Have they ever been drunk or high? How did it feel to them? Are they chasing a feeling that felt good? Have they experienced any increase in tolerance? Doesn't mean they're addicted, but that can also channel their continued future choices. Between the individual and the environment, what community norms are they getting exposed to or are being surrounding them? What media messages are proliferating, and are they high risk or low risk? And then, of course, between the substances and the environment, what's the level of access and availability? If someone's looking to change their state of consciousness, what do they have access to, right? What policies do we have? What's the enforcement? So much about a comprehensive prevention approach fits this public health headset in a really great way. So that's pretty heavy. to be saying to somebody who doesn't know substance abuse prevention well or doesn't know public health. I think this next slide says, you know, if you don't want to get into that whole triangulation, but, you know, to be able to just say, look, it's a public health issue, requires a public health response, just like with mosquito control and disease viruses, you know, that are insect-borne. There's no silver bullet, no magic, no simple solution, no one-fits-all approach. You know, we know that these problems that are public health-based don't appear in one day and won't go away overnight, and substance abuse is no different, right? We need a comprehensive approach that's based in the public health approach. And then maybe just help them understand what that means. It means that we have to be data-based and that we have to really identify populations and locations at greatest risk, and then identify what at-risk and protective factors are locally in play, because in one community it can be different than in another. So we're going to be data-driven, not assumption-driven, and we're going to develop and utilize strategies that are research-based and evidence-based and address these issues not just for kids and not just at the individual level, but the family level, the community level, society level. That's a public health approach by having all those pieces and parts in it. Now, by following this approach, I think it's important to help them understand that when we follow the public health approach, we create a prevention system that addresses both acute and chronic threats to health. Now, let me tell you what I mean here. We all know that sometimes our communities are playing what we always call whack-a-mole, right? That up pops, you know, the latest drug trend. You know, here's bath salts, there's K2, oh my gosh, opiates, prescription drugs, pain meds. And if we're playing whack-a-mole and we're just responding to the latest emerging trend and we're spending all our energy and dollars and resources on that, we're not taking the wider view and looking across risk and protective factors that regardless of substance are there, and looking at chronic threats to health that are ongoing, right? So we can't just look at whack-a-mole or the flavor of the month or that current emerging trend. That's not a public health approach. We need to be able to do both, to respond to emerging trends and acute problems while we're still able to look at the chronic threats and the ongoing. So by following the public health approach, we have a workforce and an infrastructure with the capacity to deal with an emerging new trend while still addressing the underlying causes across all substances. And that's the soundbite that I think is important. We need to be nimble. You know, and we've got research that tells us how to do that, and to be ongoing and involved with, you know, a wide lens of prevention strategies across substances, and still leaves us nimble enough to deal with an emerging new trend when something, you know, pops up, right, that's unusual. And hopefully we can forecast it and see ahead of it and get ahead of it. And we did, honestly, years ago. We had warning signs with this prescription issue 10 years ago that this was coming, right? And a lot of us were going, hey, hello, you know, look what's happening. And, you know, Oxy is this long-term and people are crushing it. Look what they're doing. And we got these early warning signs in these little pockets of different areas of the United States, you know, and we had it here in southern Ohio, you know, down in the Appalachian area, and we saw warning signs of this 10 and 15 years ago. And it wasn't until it hit crisis proportions that everybody's now more involved and the money's flying and that, you know, we have an opiate epidemic. It didn't have to reach epidemic proportions if our culture weren't so remediation-based, right? We saw the early warning signs. And if we as a field were treated more like other public health issues, and we had that infrastructure in place, this epidemic may not have actually ever happened. We would have been out ahead of it so much more quickly, and now we're chasing a runaway train, right? So we need to make a strong pitch for substance abuse can happen to anyone. It's a public health issue. Trends come and go. But if we have in place a comprehensive system that's based in this public health model and in the science of prevention, we're going to be better, you know, and we won't have these kinds of big emerging trends that become an epidemic. So that brings us to our third theme, which is prevention as a science. And those of you who have been on webinars know that this next slide is a slide we use a lot, and we love it a lot. And that is that, you know, we know that there are people out there in the community who, when there's an emerging trend, some people get more of a wake-up call because now it's touched them personally, or they're seeing it more in their workplace or their sector or their social service entity, and they're going, wow, look at this, and now I'm seeing there's a problem. we need change, and they come to join the prevention movement, right? And that's crucial, that more people are owning the problem, so they want to be part of the solution and ideally be part of preventing it, right? The problem is that the more people that are engaged but aren't grounded in the science, you could have the blind leading the blind if science isn't, being followed of what works best and what direction, and being planful about that we become reactionary instead of planful and proactive. So we always like to say that prevention is both a movement and a discipline. And we need both. We need communities to buy in to this is a problem, and it's a problem that's preventable, right? And come be part of the solution, the prevention solution for these problems. But let's do it by building the capacity across our community to be more grounded in the science of what works, so we don't spin our wheels doing, again, things that we've already known don't work, because we have the benefit of years of research. And we've got the ability and the responsibility to invest our time, our energy, and our dollars in approaches that show evidence of effectiveness. And that, I think, is a really simple soundbite that you can use over and over again. Why would we forsake the benefits of years of research to be reactionary when we have the ability and, by the way, the public responsibility, because so much of this is with public dollars, responsibility to invest those precious dollars and our time and our energy in approaches that show evidence of effectiveness. Here's another analogy, feel free to steal. If I'm doing some home improvement project and I have 2 hammers in my toolbox, and I've got a hammer that has broken in the past and I've taped it up, and I just like the feel because, maybe the wood is familiar to me and I've used it a lot, and it, feels like it feels good in my hand, and, it's my old favorite hammer. But it's broken, and it's in the past shown that it does not work, right? And I'm sitting there with my brand new hammer. Why would I keep pulling up the old hammer that has proven to fail me in the past? No matter how much emotionally I may be tied to it or I like it for some reason, it has proven to fail me consistently in the past. So which hammer would you choose, right? We need to start always with prevention-supported prevention strategies, and always remember that it is both a science and a discipline, which means there is a discipline of people, that this is their career. And some of you on the line, this is you, and some of you aren't. Maybe didn't even know that there's a prevention credentialed workforce. 40 states, over 40 states in America, and many territories in many other countries have a prevention credentialed workforce. And those are folks that have expertise that can help guide efforts at the local, regional, state, and at the national levels. And too often they are not at key community tables with that background and connection to the research, right? Because they're off busy doing way too much frontline work, and they're not at the planning level tables, right? And we need to address that. And our field needs to be better about advocating for having certified prevention specialists at planning tables, right? And there has to be that career pathing where people can move up into those consulting and planning roles and not just be frontline preventionists. We need both, right? So our field is, we got a lot of people who are aging out and retiring. And I know that's true here in Ohio. We've got a whole think tank statewide that's looking at this coming crisis in prevention. And our Alcohol and Drug Abuse Prevention Association of Ohio started a mentoring program for those mid-level prevention folks who may have 10, 15 years in the field, being mentored by people who've got like 30-plus years in the field, because they are our future elders, and our elders are about to retire. And this is a real crux time for a lot of prevention systems here in Ohio, and I'm sure we're not the only state who's dealing with that. So we need to advocate for ourselves as a certified field, and really advocate for what kind of role should we have in the community. We now have in Ohio a frontline credential, the Ohio Certified Prevention Specialist Assistant level. If you're doing curriculum-driven work in the schools where someone else already designed that curriculum, has been shown to be effective, and you get trained in it, you know how to do it with fidelity, and you know where your elbow room is, that's pretty frontlines work that a little bit of training folks can do well. Sitting down doing a strategic plan for a county, that takes someone with a lot of prevention expertise. So how do we career path our folks and get people at these planning tables where they need to be so that that science is at a fingertips, distance away from key decision-making tables? So we need to do more to elbow our way up to the table as a field, or we're going to keep getting what we've got. All right. And with that piece, we know that prevention efforts really need to be part of a planned approach, and that's our fourth theme. It's talking about that we can't be scattershot in what we do, and there's a lot of good intentions out there, especially in times of like an epidemic. And I'm going to just kind of toss a slide out there, knowing that some of you have been on some of our past webinars, so you won't be shocked by some things on this slide. Some of you may have a reaction because everything that I've got on here is an arrow, is stuff that we know doesn't work. And yet it gets done again and again and again in communities by people with really good intentions. Wow, especially focused on kids. Wow, if these kids just knew what this stuff did, they'd never do it. They knew all the worst scenarios of what could happen. So scary stories are told, and we pull out the mock crash, and we get everybody involved in that. And, so now they won't drink and drive at prom, right? This is a real big misunderstanding about how our brains work and how we take in information. And scary stories don't work even with adults, but especially with kids. And we've hit that in past webinars. If you've not seen some of that, know those webinars are on our YouTube channel, and just like this one will be, and they are free out there. I really encourage you to look back at our Scare Tactics webinar and take a look at that. But there's, Scare Tactics, mock crash, jail tour, the recovery panel kind of stuff, they kind of all go together with that research of why that doesn't work. But even just an assembly, even if the content's not scary stories, just that one-shot deal, of having that motivational speaker tear that phone book in half, on the stage of the school, that's not an effective use of time and money, right? And just handing out a pamphlet at a community fair, has its place, but it certainly isn't going to do the job. It just won't do the job. So we keep doing a lot of things and spinning our wheels, expending a lot of time and money and energy on noise, on things that just aren't really strategic and aren't planful and aren't based in the science. Effective, good, planful prevention is data-driven, where we've got local data on the local prevalence of what's our problem here. And don't let the news media tell us what our problem is here. What does our data tell us is the problem here? Right? And what are our local conditions of why those problems are happening here? Because why they're happening in our community may be real different than the next town over, or the next state over, or the next county over. We also know that not only being data-driven is important, but then from that data, we're choosing science-driven strategies, right, that are based on the research of what works, that connects with why these things are happening in our community, and all that's put together as part of a comprehensive community plan. And this is where I think things like coalitions or county or regional level funding boards doing a strong community plan with strategic planning and bringing those prevention experts to the table is going to be real important. Or if another kind of funder or foundation is doing that kind of work, the Partnerships for Success kind of pieces, the strategic prevention framework funding that's often out there to do those kinds of incentive planning grants. But even coalitions, here in Ohio, Family Children First Councils play a role. What do we mean? Who's at the table for making this community comprehensive plan and marrying our local data with the science of what works and saying what are our priority strategies that are just in time for what's going on in our community today? And it may be real different than it was 5 years ago. So we got to keep these plans up to date. So I think that makes a real strong case for, coalitions, because they are an excellent means to achieve a planned collaborative effort across community sectors where everyone sees how this issue affects their sector and their own missions and visions of what they're trying to do and how substance abuse can sideline that. And they come together to be part of the solution, right? And they own it within their sector, but they also become a champion for how everything in a community is knitted together and weaves together. All right, and our fifth theme is that prevention is more than education. There's a lot of pieces to the puzzle. Education is but one. So let's take a look at, outside of education, what are some different frameworks for what else prevention is? We happen to love the Prevention Institute's matrix or spectrum of prevention, and we'll include that as an attachment in the emails that we send out to everybody after the webinar, along with a PDF of the handout of the slides. So we will get you this if you don't already have it. The Prevention Institute isn't specific to substance abuse. It's really a lot of other health and prevention issues across a wide spectrum of social ills. But prevention's prevention when you talk generically about, what we should be doing, what is the spectrum and the levels of work. So as you start at the bottom at level 1, that's down at the individual level, and education fits there, right? And there are things you may do to educate people across even all 6 levels, but education is not the only thing you're doing, right? So we're strengthening individual level knowledge and skills. That does happen best through interactive education, and with kids that there's really excellent school-based curriculums. A lot of good research on that, but schools' capacity and ability and willingness to put the time and energy into that is down because of everything else they're burdened with. So sometimes we have to make a case to a school for why prevention meets all their other needs, right? That you've got someone sitting in a chair ready to learn because they're substance-free. You're going to get more from your other things, and it's not just about substances. Social emotional learning and prevention connect beautifully. So being able to make that case to someone like a principal or a superintendent. So that's level 1, and again, not just for kids. We need to strengthen individual knowledge and skills across the lifespan. As we work from the individual up, you can look at reaching out to groups of people that can help promote health and safety, and that's community level education, where maybe we're now targeting different groups that this issue crosses over with. Educating providers who will then transmit the skills and knowledge to others, because this issue crosses every sector of a community. So who else is touched by it, and how can they be engaged in doing prevention and infusing it into other work they already do, and that they become part of the workforce, but they don't have to be credentialed. They don't have to, they're infusing the work into what they do. It's what we might call ancillary prevention providers, whether they be teachers, whether they be other mental health promotion folks doing a lot of other good work. Fostering coalitions and networks is a prevention level of the spectrum, where we're convening groups for broader goals and greater impact, and not just for community level planning, but also to engage in things higher up on this spectrum, where we're changing organizational practices. Maybe we're looking at a school policy or an athletic team policy or a workplace policy. Maybe we're looking at systems, having memorandums of understanding and how we're going to work together as systems. Maybe law enforcement in the school need a memorandum of understanding of how they deal with violations, right? We see that with off-campus codes of student conduct with college campuses and local law enforcement, and how that memorandum of understanding may work. So there could be systems and organizational practices, but also all the way up to policy. And that doesn't just always mean legislation, but other kinds of policy. That can be local, that can be state, that can be national. But even looking at codes and code enforcement and local ordinances and your regulatory bodies, and what roles do they play in all of this? We've had some really incredible things that have happened through coalitions, dealing, for example, with a party house, a chronic party house in the neighborhood with a ton of alcohol, a ton of drugs, neighbors frustrated because of all these cars parked on their street every weekend. They can't even get in their own driveway because people are just parking wherever. And the neighborhood got together and they did their petitions to all houses but one and got everyone to agree to change the parking on their street. And so they, next thing you know, the signs go up, no parking here. And now the tow trucks are called next party weekend, right? And they changed the physical design of their community through policy, right? Through local level ordinances and codes. And that was an environmental change. So level 6 isn't always just like legislative, right? Changing laws and policies that influence outcomes at the local, regional, and state levels and beyond. Okay, so last theme that we have is that we have to invest in comprehensive evidence-based prevention. And when we talk comprehensive, I want to just point to the most predominant model. There are a number of models, but the most predominant model that prevention leans into these days is the risk and protective factor model or framework. It's more than a model. I think it is a framework. And as you look at that framework, there are very specific risk and protective factors that have been identified in the research as a whole list at the individual level, a whole nother list at the peer level, a list of school, family, and community level risk and protective factors. So that would be a model, if you're not familiar with it, to definitely get more ingrained in. But, you know, when you're talking to a stakeholder, they don't need to know and understand that whole model. They just need to understand there have been risk and protected factors, research-based, that are identified at each of these levels, and that we need to work across these domains and across the lifespan and across community sectors if we're going to get anywhere, right? We can't just, target one thing and say we did something, right, if we want it to work. So we need to be more comprehensive in what we do. So here's kind of a summary of effective prevention practices, that it's based in data-driven planning. That's a soundbite you need to get out to people and explain and help motivate them to invest in time and energy or money in. That effective prevention is research-based and using strategies that have been proven to work, which means we're certainly not spinning our wheels doing things that have been proven not to work. At first, at minimum, do no harm, right? Don't waste time and money. And particularly some of those things that have been found not to work can actually backfire. Effective prevention is relevant to diverse populations and across the lifespan. So we need to do everything we can to ensure that our strategies are culturally competent and developmentally appropriate, and that they don't just focus on kids. And that we're addressing both individual and environmental factors in what we do, and that effective prevention is evaluated and accountable. So it's not a one-shot deal. You can already see an assembly doesn't fit any of this, right? Bringing in that big keynote speaker for the assembly hall at the school doesn't fit any of these bullets right there. When we're looking at our next bullet, that it's comprehensive with multiple strategies for multiple targets, populations, and systems. And everything we're saying here is lining up with public health approach, by the way. Community empowering. Effective prevention will empower a community and fosters ownership of problems and their solutions, right? And effective prevention is committed to the long term, right? These problems did not happen in one day. They will not go away overnight. So keep your sound bites in mind, right? And some of them you'll find throughout this presentation when you go back with your handout. And last but not least, they need to be replicatable. Replicable? You figure out how you'd like to pronounce that, and you do that for yourself there. That means they can be replicated, and therefore they're documentable, right? So we have accountability because so much of what we do, a large proportion of it is in the public sector and done with public dollars, right? So we have our key advocacy themes that we've covered in this very brief time together, and we are at that point where I think Derek's been taking the questions that have been rolling in, and we'll see what questions you have.
Thank you, Allison. And if you do have a question, please enter your question in the question section of the GoToWebinar navigation panel, and we'll just start at the top and kind of work our way through. And a lot of times we have additional questions that kind of follow up from that. But just as a reminder, a link to the recording of today's session, along with the PowerPoint presentation, the resources that Allison made reference to, a certificate of attendance, and additional things will be sent post-call by Friday. So we'll expect that to be in your mailbox by Friday. And for the first question, it would be, how do you feel about random drug testing in schools as a prevention tool? Now, this is something that we spoke about in our Scare Tactics webinar to a little degree. Would you like to speak any more about that?
Just very briefly on that. You remember that we did that in another webinar, Derek. I'm just very impressed with your brain. She stalled for a moment for an answer. So as we look at the random testing, when I do a lot of drug-free workplace work, and we know that random testing has been a proven deterrent and a preventative tool in the workplace. I think it can do that in the schools, but boy, I've got a lot of red flags about it. And here's a couple reasons why. You know, drug-free workplace for a private employer in an at-will employment state and requiring people to consent to and submit to testing as a condition of employment in a private company in an at-will employment state, there's legal issues there that make that cleaner, right? You do this particularly in a public school, and it's required, versus is it random testing only for extracurricular? And that's where a lot of schools are focused doing it because there's more elbow room legally for that versus 100% of the student population. There are some Fourth Amendment issues there from our Constitution that are a red flag for me. And I don't know if I would rather, actually I do know, I would rather that we put all that money that would cost to concerted prevention, evidence-based practices before we give up the ghost and try to just be all penalty focused with our kids. So there's my answer. Not representing the opinions or views of Drug-Free Action Alliance, but that's my answer.
And that is a good point. And from the research that I saw in looking at the effectiveness of the drug-free or the drug testing policies within schools, it was shown not at all to be effective for males and only marginally effective for females. And that was only in schools that had a positive social climate, which is only about a third of the schools. So all in all, it's not the best use of prevention dollars and can also kind of set forward that myth that everybody's doing it. So definitely think we could direct our prevention efforts in better ways. And Debbie's question is, I agree with prevention credentialing. It's related to credentialing. How do we help public health realize that there is already a workforce trained and ready instead of them taking it over?
Not sure where you're calling from. I know here in Ohio, we have been lucky enough to have a membership organization in Ohio that is a free voice advocating for the field and that does advocate, especially around our workforce of credentialed folks, and that's the Alcohol Drug Abuse Prevention Association of Ohio. I know a few other states. I know Kentucky has something similar. That might be a place to start, that if your state has one, really get to some of those meetings. Volunteer to be on the board and say, this is part of our issue, and how are we going to advocate more, and do we need to do a workforce survey, and how do we advocate for ourselves better? And if you don't have one of those organizations, I would start having coffee with some other preventionists and say, do we need an organization? How are we going to make it happen? Because if we don't come together and start speaking up for ourselves, nobody else is going to do it for us.
And Allison, back to credentialing for a second. You had mentioned credentialing and being an important piece. What states have credentialing programs?
I don't have that off the top of my head. I know there's over 40, and I got that by going to the IC&RC, the International Certification and Reciprocity Consortium. Ohio is a member, as are many, many states, so that if I'm here in Ohio with my credential and I move to, let's have fun, Hawaii, I could go on that website and see if they're reciprocal and what level of the credential do they accept, and then I would have a Hawaii credential without doing any additional work or money, versus like we're reciprocal, we have 3 credentials, and we are reciprocal at just our Ohio Certified Prevention Specialist 1. There is a level above that that's a 2 that you would still have to come in and do your own work here in Ohio to get that. So I recommend going to the IC&RC website. Let me say that again. It's the International Certification and Reciprocity Consortium. And that'll tell you what member boards are out there throughout all the states.
And that website for IC&RC is internationalcredentialing.org. Again, that's internationalcredentialing.org. The next question is from Young. And the question is, on the prevention and intervention continuum, we may want to add another level of the spectrum, enforcing policy and legislation, i.e. enforcement should be considered as its own level of the spectrum. And I know we're going to talk about that more at our next month's webinar. Is there anything that you'd like to add to that from an environmental prevention perspective?
I'm not sure I caught the intent of the question.
Sure. The focus that he's looking at is really looking at prevention and intervention and really having a need for the enforcing policy and legislation piece. And that really does fit within the environmental prevention perspectives that we look at here and is something that we will be talking about more next month.
Yeah, rather than doing next month's webinar in detail right now, I just will let you know that we're going to look at how the advantages and benefits of environmental and how we make a case for it, as well as what is the scope of environmental, that it includes changing community norms, access and availability issues, media messaging, policy, and its enforcement. That's that CAMP model, if you followed those initials. And we are going to dig into that in a lot more detail. I'll tell you honestly, for the last 10-plus years, more, 15, it's been the main focus of my work, particularly because, you know, last 12 years I've been here at Drug Free Action Alliance, so actually it's easily 15 years plus that that's the only kind of prevention work I've been engaged in. So I'm with you. I agree. And we have to do more to help people see that prevention is not just for kids and it's not just in schools.
And this question is also along the environmental prevention guidelines. And again, we'll talk about it next month's webinar. But the question is, how important is the reduction of availability and prevention efforts? Do you have suggestions for accomplishing that task?
Yeah, here's the problem. I almost feel like I need to take off my headset, Derek, because you are on such a delay, and I'm hearing you both ways, and I got lost in that again. I'm very sorry.
Okay.
Yeah, let's do that.
Okay, so again, the question is, how important is the reduction of availability and prevention efforts? Do you have suggestions for accomplishing this task from Javier?
Wow. That, I know it's something we can do in our next webinar as well. I think that, that's a very big question to just answer off the cuff. Where I used to be able to send you was Center for the Science and Public Interest. They had all that research so easily available online. But instead what I'm going to do is recommend you go to the Center for Disease Control Community Guide, where they make, particularly from the alcohol standpoint, they have links to all that research on access and availability and outlet density and days and hours of sale and incredible research about which of these strategies have the strongest evidence and where's the weakest evidence for these kinds of environmental strategies focused on availability. So I know we'll touch on that in our next webinar, but in the meantime, I think I'll just point you to the community guide.
Thank you. And this question is from Sue, and Allison, I'll take care of this one. How can I access the webinars mentioned on the Drug Free Action Alliance website? I am getting an error message that you do not have the necessary permission to perform this action. And Sue, all of our webinars are available on our YouTube channel, and you can access the YouTube channel on the top of every single one of our web pages. It's next to our Facebook and Twitter links, so you can just select the little YouTube icon, and that will take you right to the webinars that we have listed, not only the program webinars, but other webinars that we have related to our Youth-Led Prevention Network, our Parents Who Host programming, and other such videos that are available there. So again, just check the YouTube link at the top of any of our web pages, and we'll get it to you. Are there any specific resources already created using the resources to share with legislators? And this question is from Kaylee.
What I would say is that we've got some other resources that we're going to send you to, and I'm going to go ahead and pull that slide up. So we'll send you these links in your email so you can more easily get to them. There's one called Prevention Saves Lives and Money that's an excellent PowerPoint from another group. And the Prevention Tactics, Substance Abuse Prevention, Benefits Outweigh Costs. A lot of this is about the economic case. The Health Policy Institute of Ohio did an excellent guide to evidence-based prevention. And really helps define what do we mean by evidence and evidence-based. And then there's also a return on the prevention investment. Money spent up front can save costs down the line. So we'll definitely get you links to those resources if that's what you were asking, for other further tools that you can use to build your case.
Thank you. And this question is from Leslie. How can we find who else in our community is working on these efforts? And Leslie, I think the best way to do that is to look at the mechanisms that you have in place in your community. I'm not sure what state you're from. However, there's drug-free community grantees that are throughout the country, as well as a national prevention network, key affiliates, and every state has an NPN. So I would recommend that you would connect with either of those entities to see who else you might be working with. Also connect with your local United Way or other social service agencies. Allison, do you have anything else that you would like to add?
Check to see if you are a state that through that ICNRC website that has credentialed prevention professionals, because that is public document lists that they ought to be able to share a list with people in your area or region that are certified in prevention if your state has that.
And this question is from Heidi, and really this is about NREP. And the question is there a resource site that provides a listing of effective evidence-based prevention strategies?
Love that you asked that question. On the slide in front of you, that Health Policy Institute of Ohio Guide to Evidence-Based Prevention, the best piece of paper in that about 25-page document, has a matrix of a number of the registries or sites that point you to evidence-based programs. NREP is but one. Please know that NREP is more of a listing. Anyone can get listed on NREP. You need to know how to use NREP to look at the scoring that someone got to know if it truly is effective. So they're just a listing, like a directory, and here's how their research is looking. Just because someone is or a program is on NREP does not make it like it says it didn't. It's not saying it met the bar. Anyone can be on NREP now. That's changed over the years, and you have to know how to use NREP. So what I love about the Health Policy Institute page and the Guide to Evidence-Based Prevention is they have a beautiful grid that points you to other online directories or registries of programs and tells you how to use them.
Thank you. And this question is from Carol, and her question is related to the stat for the $746 that it costs for excessive drinking per person. Is that based on an annual basis?
Yeah, all of those stats
Were an annual. All those stats were an annual basis, and that one, particularly for alcohol, came from the Center for Disease Control.
Thank you. And this question is from Lindsay. How would you suggest making the case for prevention in schools that are constantly feeling the pressure to prepare for state testing and do not want to sacrifice time for activities and prevention curriculum?
I feel like some of what we've talked about here can start to help make the case, but with schools, you almost need to make a very special case. And I think some of it is first just acknowledging where they're coming from and what they're dealing with. You know, and maybe that's an idea maybe Derek and I can talk about for a future webinar too, is when we're looking at, like, there's a community here in Ohio that when the economy crashed and everyone else was losing all their school-based programs, their schools were buying their prevention services as a provider because they had done the groundwork of going and doing what they call in sales in the corporate world is discovery, where they were talking to the schools and saying, what are your biggest problems? What gets in the way of you doing your job? And being able to tie all of that to the substance abuse. And they started first with, we've got kids in need and kids in pain. And so they started with intervention first and started alleviating that pressure release valve piece for the schools with those wraparound services, and then use that as their end to start to build. It'd be great if we could get ahead of this. And here's how prevention lines up with your education goals and social emotional learning and talking their language as a school. That's a short answer. A longer answer could be a whole other webinar. So we'll make a note of that as a potential future webinar.
And this question is from Lynette as kind of a follow-up to the drug testing question. And her question is, what about doing the testing when required for sports and being on a team, also making clear that this is a requirement for sports and other activities? And Lynette, I think that's a great question, and I think it can be much more broader than just student drug testing, but having a clear and concise student policy related to substance abuse. So there are things that are in place that are enforced effectively and consistently regardless of what the sport is or what the other activity is. So we've got policies, the same policy for being involved in choir as you do for being involved in football, as you do for even things that are not really part of the extracurricular activities, such as just having the availability to drive to school. So we'll talk a little bit about that in our policy and enforcement piece for next month's webinar and kind of get into additional more details related to that. The next question we have is, I was wondering if you have any advice and or resources for adapting our work message so that it is relevant to diverse populations. She works in Vermont with many new Americans, particularly Somali and Nepali immigrants, and any suggestions for adapting a evidence-based prevention message for a particular audience. And I think that would really just depend on the audience that you have, being really understanding of cultural competency and the way that their communities are built and addressed and what their social nuances and mechanisms are, particularly when you're looking at Somali populations that have a large Muslim base. The use of alcohol at all within the Muslim spectrum is frowned upon, so there might be some challenges there and some disconnects that you might have to focus on. Allison, would you like to add anything else?
Yeah, it's hard to go into the level of detail, in just a quick question and answer after a webinar, because cultural competency is a huge topic. And when you're talking in workplace specific, I think that's the area where there's probably been the least done in prevention anyway. Not saying it's not needed, not saying there aren't some people out there doing incredible work. We have some folks in Ohio doing that. But when you're talking adult messaging through the workplace that's also culturally competent, you've just really narrowed the field of things that I could point to where there are resources that already exist. So what I'm instead going to do is say, it sounds like you're a trailblazer. I say go blaze that trail and lean into the research that you can, and you create that database that other people who follow you are going to be able to do. I hate to do that, but I don't have a resource for you.
And this is more of a suggestion than a question from Debbie. And hers is that she would welcome the webinar on evidence-based programs in public schools. And we did kind of address that earlier this year in, I can't remember if it was August or September, But it was either one of those months when we were back to school and we talked about that. So again, check out our YouTube channel and see that recorded session. The next question is, great information. How do we talk with people who think early intervention programs are prevention?
I think analogies are always a great thing. So find an analogy. For me, I use the mosquito analogy. I may fall apart here. But, other illnesses, that if somebody, identifying someone who already has a cold or has, let's say, a heart condition, and intervening with that and then getting them into the level of care they need didn't prevent that from happening. Another thing to look at might be the Institute of Medicine and how it really identifies universal versus selected and indicated population, and dig into some of that information and research, which also will have analogies to other health issues, and find those simple analogies. I'm thinking even in tooth care. We go to the dentist, and I just recently, at age 40, had a drill going on and a cavity filled for the first time in forever. That was intervention and treatment, to find that, because it got to that point, but where for what was going on in my mouth. But I still brush my teeth every day and floss and do the fluoride-based toothpaste, and we still need the prevention, and that has kept me out of the dentist chair for an intensive treatment for a really long time. So again, use those analogies, so that they go, well, no, duh. Some of it's the hang-ups about substance abuse. So go sideways on them and do an analogy to something that everybody already understands and gets.
And this question is from Lynn, and it's related to scare tactics, which we already discussed in maybe November or October webinar. But just to recap, her question is, would you discourage a group who has already scheduled a mock crash pre-prom event? The people involved are the first responders who believe it can be an impression on the kids involved.
This is a tough one because some communities, it's more than your first responders. You may have the mayor. You could have someone from city council. I mean, you could have a lot of big players, and this is like a splashy media event. And you've also got different sectors of the community embracing that substance abuse or alcohol or drugs is somehow an issue in your community, and this is their big public moment to do something about it or show that it's important and to do something. So you don't want to lose that community engagement with those key stakeholders. So what I recommend is change from within. How can you come be part of that planning table and say, you're right, this is an issue, and start to share some of the research. Find out where they're coming from and why they see this as the way to go, and more of what's their vision, what's their mission of what they're trying to accomplish. And it may not be in this first year. You may have to let it still happen in this first year. And just use it to start building the relationship, do some discovery, start doing that just-in-time learning. Share some of that research from that Scare Tactics webinar or our Scare Tactics document you can find in our online store, and give them those 4 reasons why Scare Tactics don't work, and slowly start to persuade and make change from within. But then you got to be able to replace it. You better have something ready to say, what else should we be doing? But you don't want to lose that community engagement either.
And this question is from Elizabeth, and her question is, how can I get information about the Scare Tactics webinar? And again, you can just go right to our YouTube channel, and it's a few months past, so you can see all the other videos that we've been doing since then. But you can search there, and you can find that document, and hopefully find some other things that would be interested for you. And the next question is, could you repeat that information about the credentialing, please? That is from Tricia. And again, the credentialing information would be related to IC and RC, and that is... Oops. I'm sorry, I had Allison muted. It's the International
Certification and Reciprocity Consortium, and I believe you had said the website was internationalcertification.org. Previous question that someone had asked, but if you just Google ICNRC or International Certification and Reciprocity Consortium, you will find links to both prevention and treatment credential member boards, and be able to find the member board in your area.
Thank you, because I looked up the website and then it left my head as soon as it left my lips, so thank you. This question is from Catherine, and this will go back to one of our other webinars that we had talked about, our Parents Who Host campaign. Hasn't been tested and found to be an effective strategy. And I would recommend that you review the webinar there to really talk about the evaluation efforts that we had under that. The short answer is that it has been evaluated extensively, and it showed progress in effectiveness in changing key changes. Thank you. And again, go back to that. I think it was in November or December. They're all kind of running out of my head right now, but recommend that you check that out there. How impactful have the active existence of substance abuse prevention coalitions been? This question is from Patricia, and Patricia, for that I would recommend you check out our coalitions webinar and why coalitions work, and that was, I believe that was December, because last month was marijuana. I need to make a list of this. Thank you. So check that out. And Nikki's question is, can you please send a direct link to the community guide?
Yeah, I'll make a note. Yep.
So Nikki will definitely take care of that. And what is your opinion on substance abuse and mental health joint efforts to holistically serve the entire family? And this question is from Lonnie. And I think it's important to look at all aspects of health and wellness when you're working to address prevention. So certainly mental health issues and substance abuse issues run hand in hand in a lot of varieties. So I think that it's imperative that you look at a comprehensive approach when addressing families. Allison, do you have any other thoughts?
Yeah, just some very quick, let me point you to kind of thoughts that when you're looking at mental health and substance abuse, as Derek said, many of the risk and protective factors really cross over there. Another area when we're looking at family and early childhood development pieces is also trauma. And some of that research on early childhood trauma and the family connections with that and what families can do to help young people heal from that and what that means as a risk factor for substance abuse and other mental health concerns and behavioral health concerns. And for that, I'm going to just name drop Bruce Perry as probably the trauma expert out there nationally and encourage you to Google that.
Thank you, and we only have time for 2 more questions. The first one is from Patricia, and her request is that we send the website for our IC and RC in the follow-up email, and we can definitely do that. And I looked it up while we were chatting, and again, that is internationalcredentialing.org. And the final question that we have time for today is, how do you talk with people who think intervention programs, oh, I'm sorry, we talked about that one already. I didn't click it off. Credentialing process recently changed in Ohio for OCPS 1 in requiring an associate's degree to qualify. If you have the hours needed for OCPS 1 but not the associate's degree, is there a way to be grandfathered into OCPS 1 if those hours were attained before the change? And this question is from Alice. And Alice, I would definitely recommend that you connect with the board Ohio Chemical Dependency Professional Board, thank you, Allison, for that information, and it's pretty specific to Ohio and the levels of certification, so definitely recommend that you check with Marilyn there, and she'll be more than happy to assist you. And with that is all the time that we have for you today. If you have additional questions or resources, feel free to contact us at Drug-Free Action Alliance. That phone number is 614-540-9985 or email at contact@drugfreeactionalliance.org. Thank you again for all of your questions, and again, if there's anything else that you have, please feel free to send that to us. In our efforts to continually improve upon the presentations that we provide you with, we do greatly value your feedback, so a session survey will be sent via SurveyMonkey post-call to really get your feedback, to not only see what lessons and pieces of today's session were helpful, but also other topics that we could look to integrate within our future sessions. Again, thank you so much for your time, and is there anything else that you'd like to mention, Alice? Oh, thank you. Allison is prompting me for our next webinar, Environmental Prevention is Sustainable Prevention, and that will be March 18th from 1 to 2 p.m. Eastern Standard Time. So please feel free to check that out, and we look forward to really delving into environmental prevention strategies to really talk about some of the questions that you had, particularly when we're looking at policy and looking at policies and other things such as that. So thank you again for your time. We hope that you'll join us next month. And in the meantime, for those of you that are in cold climates like ours, please stay warm. And for those of you that are in warm climates, just give yourself a pat on the back for being so intelligent to live in such a place. So we will chat with you next time. Thank you all.